Good evening, ladies and gentlemen, dear doctors and esteemed faculties. I'm Dr. Krishna Prasad, welcoming you all for this, if not for the heart of the press, but otherwise on the angle of the new year, the novel approaches in COVID-19 coming to you as a webcast E-Conclave. Well, to put the things at the outset, I would confess to probably start the event to say the fact that yes, as a clinical researcher and a clinician by heart, I've had evolving interest in probably characterizing the patients for defining the pharmaceutical weapons to be redefined. And that's where probably otherwise it's probably a homecoming for me with this distinguished audience where we have been trying to get together and probably otherwise, if not evolve, but probably also explore some of the medical messaging and probably otherwise standardize them to speak of the least, if not as bronchial, but probably as difficult asthma and probably otherwise also as echo. But ladies and gentlemen, I would also convey the fact that yes, while we are looking towards the real world evidence to actually redefine and re-weaponize our therapeutic strategies, what do we have on hand? I think what do we have on hand is nothing but in COVID-19, which has probably all the more evolved in becoming all the more evolved in a different characteristic. While we are trying to hit it hard with as many strategies, including vaccination, it probably suffices to say that yes, it's probably becoming as a double-edged weapon. And to say the least, is the characteristic or probably this clothing that it wears is in the form of a variant that we are flummoxed about our own effectiveness of our own strategies. So to probably dwell on the clinical perspectives on the management of these challenges around the COVID-19 and its management, right from mild, maybe moderate, maybe non-hospitalized cases, I think I should thank the stars, not in the sky, but probably in this panel who have probably given the time and also seconded to this proposal to have a freewheeling, interactive, yet a pertinent discussion on the new approaches and the new targets which have been probably being identified, which could be hit hard. So in this line, we are having some of the distinguished panels which have been coming on board. And I would like to straightaway start with a few words with some of these faculties who have been quite enriching in their journey for the unraveling of the mysteries around COVID-19. So right at the helm of the affairs, it's going to be the first session to trigger the thoughts on how do we look towards managing non-hospitalized COVID-19, right from the guidelines which have evolved both at the international and national levels, and then probably we are looking towards the clinical pearls of its implementation in the local practice coming in from Dr. Deepak Talwar, who is again requiring no introduction as a senior faculty, senior consultant and pulmonologist at Metro Institute of Health Sciences, Noida, which has seen some of the deluge in terms of evolving cases of COVID-19, be it the first, second, and maybe otherwise now upcoming wave. So he has been in the forefront of both academics as well as scientific information dissemination. He has been also in charge for the DNP teaching in respiratory medicine, sleep medicine, and critical care, where he actually specializes. And he has over 80 research papers in national and international journals. And yes, I keep on looking at them just off and day by day. And they have been probably getting published in some of the peer-reviewed index journals of high repute, including NEJM. So welcome you, sir. And we would then go on to Dr. Kumar Doshi, again, Mumbaikar. Yes, welcome you, sir. I mean, I have moved on to Ahmedabad, but yes, I can't forget my roots. But yes, again, a state which has seen again evolving strains of COVID-19, and we are again challenged on the challenges of this new strain. And to speak about the current new adaptations and probably new approaches, I think Dr. Kumar Doshi is going to speak on new age antivirals, making the right choice, if not making a choice. So he is a senior consultant pulmonologist at Sunflower Clinic, and he is heading the Department of Respiratory Medicine at Asian Cancer Institute, Mumbai. He has had immense experience in sleep medicine, interventional pulmonology from Brussels, and he has been faculty at both national and international events. Needless to say, has had several national as well as international publications and a wonderful orator, to say the least. So with that, I would then go on to our own, I think a most father-like figure, that's Dr. Jay Chandra, right from Hyderabad, which has again also seen some of the key aspects about the COVID behavior and the COVID strain, which is again also evolved. Welcome you, sir. As a senior consultant and interventional pulmonologist at Hyderabad Rinchi Hospitals, he has been again a very active member at the scientific and academic forums. Needless to say, he has been affiliated and an active member of ACCP and ICS with special interest in interventional pulmonology. And in fact, he was one of the first to introduce and look upon the entire spectrum of interventions in the state. And he has also been one of the key pioneers in flexible bronchoscopy in pulmonary diagnostics in Hyderabad, as well as pediatric bronchoscopies. So he's going to be our esteemed panelist to take forward the clinical discussion, which is going to be revolving around making our own behavior all the more up to date and probably aligned with the new pieces of information, if not to get them implemented in real world practice. And then again from Jaipur, we have again a senior consultant pulmonologist, that's Dr. Pradyuman Sharma, who would again join us as an esteemed panelist for the deliberations which are going to be happening. And he is been a prolific orator, delivered almost about 150 lectures and chaired almost about 600 sessions at both state as well as national events. So welcome you. I would probably look towards a really if not a rapid fire, really live wire discussions happening on that front. And yes, he has been on the life membership of various national bodies to probably look at some of the clinical experiences coming very much into the forte. So with that note, I would also take this time of the audience who has in replete numbers as logged in, as I can already see right now, who have taken the time out, and probably otherwise I would probably reassure the fact that yes, they are getting a wonderful, enriching, engaging discussion, which is all the more pertinent and required in the current context of COVID-19. So with that, I would now invite Dr. Deepak Talwar to run us through on his discourse on probably what could be the real world approach towards non-hospitalized COVID-19, which seems to be, if not fraught with several options, probably we seem to be fraught with several choices available at our disposal, but probably very few seem to be making the cut on that line. So over to you, sir.
Thank you, Krishna. Good evening, everyone. I can only say that I wish you all a very happy New Year 2022, and thinking that perhaps this is going to be the end of COVID-19. But I cannot claim that whatever I'm saying may be true, because, well, 2 years ago, we never thought we will be in this situation. And come to think of it, in November 2021, did we anticipate that the numbers will increase again from 5,000 to 25,000? That's what is happening today. Again, another wave has come. We have suffered and we are continuing to suffer. And in fact, there is a time when we used to think that, okay, enough of COVID, we need to do something more. And then the COVID comes back and takes you again into the same scenarios which you have gone through once, second, and now this is the third time. So, you know, I am today on the backstage. Actually, I am like you people who are thinking that, you know, what is this? What is this happening again? And after the Delta, I think everybody has a very high reservations in accepting that the therapeutics have making any significant change as far as the management of COVID-19 is concerned. We have been using all kind of refurbished drugs, and there has been a list of them which has been used, and we have all thrown them out. And this time when the third wave is coming, and we all know that it is already there. Look at the numbers, look at the R value. We are now preparing ourselves to treat the patients. And what we are preparing ourselves is to treat a lot of non-hospitalized patients. That's what we are looking for in Omicron in comparison to what we saw in Delta, where the hospitalizations run to thousands and thousands of them. So my job today is to talk about a little bit of treating this non-hospitalized patients, and I'm sure you will realize the frustrations which I feel may be passed on to you also, because it's not different. It is just changing the same way. And I think back to square one is something which is happening all the time to us. And we always think that we are wiser, but it's the COVID which tells us that, wait, you are not as wise as you need to be, and perhaps you will take much more time to do so. So I'm just going to talk about very briefly about, as I said, that, the entire presentation today, the star is going to be Dr. Kumar Doshi. He is going to talk about it. I'm going to talk about fallacies. I'm going to talk about shortfalls. I'm going to talk about unmet needs. I'm going to talk about what we are unable to do. And I think at the end of this 10 minutes, you will say that we are also facing the same thing. What's the new Dr. Talwar has said? Maybe I'm not going to tell you the same. I am just echoing whatever you people are saying to look for that. Is there any hope for us in 2022? That's what I'm doing. So I am struggling. You are struggling.
Dr. Talwar is going to screw me on each and every ground which he has spoken right now.
So we have this about a day or two ago, but I know that today's figures have already crossed 25,000 cases per day in India. So obviously we are into that stage. We're multiplying into 2 every day. So in fact, this is faster than the Delta, what we are reaching. And I think in 2 weeks, we will be having a huge numbers where we will be wondering what to do with these symptomatic patients who are not hospitalized, how to treat them, or do we really need to treat them? I'm sure that after the 2 waves, we really start working and wondering, do we really need to treat them or not? What is the difference this time in 2022? We have a large number of population which has got immunization, either 1 or 2 dosages, and a very few which have got a boosters, or so-called as the other dose or the third dose, by whichever means they have got it by traveling or whatever is there. We have a lot of population which has got previous infections, and they thought that after getting an infection, they will not get it. But when Delta came, lots of them got that. And now people know that even if you have got an infection, you may still get the third one, which is the Omicron right now. Seroconversions. This is different because by now the data suggests 80 to 90% of the population across the India has got it. So maybe somewhere 70%, somewhere 90% and above, like Delhi, 90% above seroconversion is already there. And of course, but with all this, armed with all this, we thought that we are going to be immune to COVID-19. But the new mutant, which is the escapist variant which has come, is escaping everything what we had so far to fight with COVID-19. But at the most, the data suggests that they are causing less severe cases. So all our immunity, infection, vaccination, conversions, accidental conversions, whatever has happened in the past is only making us, in a way, less prone to develop more severe diseases in majority of patients because of whatever immunity we have. It is just trying to protect us in some manner, not completely, but in some manner. How much we do not know. Also different in 2022 is that all the drugs which we used in first wave and second wave are out. Azithromycin, doxycycline, hydroxychloroquine, ivermectin, and I would even add to this list favipiravir. They're all out. Now, what is left with? Inhaled budesonide. It is the only one which has stood the test of the time, and it is just a symptomatic treatment. Makes you feel better earlier. That's all. What about progression of disease? What about progression of disease to hospitalizations and death? No role so far. Then there is monoclonal antibodies. And this is particularly for those who are at risk for the poor outcomes. So the challenge in non-hospitalized COVID-19 patients is to decide who needs treatment and what treatment. So obviously only those who need treatment are the ones who are likely to progress, likely to require hospitalizations, worsen with the complications, are prone to be more likely to die of it or suffer from even long COVID. and more than 90% of COVID-19 patients of Omicron will be in this group where they are going to be non-hospitalized, and you need to choose them, that these are the ones who need to be treated. And we know from the risk factors in the past two waves, older age, immunocompromised people, organ transplant patients, chronic kidney disease patients, diabetes and obese patients, and patients who have other chronic underlying diseases like of lung, heart, or liver, all at high risk of progression of the disease and worsening and dying of it. And this is the data which shows hypertension, diabetes, coronary artery disease, and COPD are the four major important risk factors which lead to, in way to predict that these are the patients who can actually progress and die. So the morbidity risk in this high risk traits are the age, people who are more than 18 years of age, and obviously the elderly more than 65 years, where there's a mortality risk, predominantly males, and of course this all risk group which I have already discussed with this. The question is, we need to identify these because they can worsen from mild disease to moderate to severe and die of it. The problem with COVID-19 is the new variants. And now we have the new variant which is circulating, Omicron B1.1, 0.5 to 9, and of course the Delta. And there is already talk about it. When the Delta and the Omicron are combining together and they are calling as Delmacrons, and Delta and Omicron together, God knows what havoc it will create for us, but it is ever evolving. And ever evolving from the perspective that those patients who are immunocompromised, who are aged individuals, will require some kind of a therapy. And it requires a therapy which is primarily acting on the virus. And it should be safe and it should be efficacious also. Where is it? So as I said, that as we moved on, we had this monoclonal antibodies in the last couple of months, which we were using, although we missed the boat for treating in the peak of the Delta wave. But after that, whatever was the tail going on, got some exposure of using monoclonal antibodies, Casmet. And the issue is that the Omicron is able to evade the effectiveness of even this antibody. So what do? So look at the data. The Omicron is the one which is obviously in the lab, it is likely to be showing that it is not going to be active and effective for Omicron group. This is not the real life data. This is only a lab data, only a prediction. But it is worth noting that the monoclonal antibodies, all these tests were done when these were not in circulation. What we are talking about is the Delta and the Omicron were not in the circulation. Have we come up with a new option for non-hospitalized patients? And I will bring your notice to this paper published in New England Journal of Medicine last year late. But again, a very, very thought-provoking, especially when you are hearing that remdesivir has no action as far as no role as far as the COVID-19 is concerned, particularly when WHO comes up with that kind of a statement. Can an antiviral like remdesivir have no role in killing a virus of COVID-19? And then we know that the way we have used, and there are lots of controversies, I won't go into it, but this paper brought in that if you use 3 days at home remdesivir to these patients, in non-hospitalized patients, or bring them to the hospital and give them injection loading dose of 200 milligram on day 1, 100 milligram on day 2, and 100 milligram on day 3, it results in 87% decrease in reduction of hospitalizations and death versus a placebo. So this is bringing in the entire concept that the antivirals have to be given early onset of or at the earliest point when the disease takes place or the disease starts with COVID-19. Now, this is something absolutely contrary to what we have done, where you need to wait till the patients become hypoxic to be eligible for getting remdesivir. Absolutely wrong. And according to me, when the virus is high, hit the virus with the antiviral And that's this trial, it in fact shows that 87% reduction in risk of death and progression and hospitalizations in those who are non-hospitalized and given just 3 days of remdesivir as soon as they develop the symptoms of COVID-19. So if you look at this other guidelines, we don't have any guideline to tell us what to treat these non-hospitalized mild to moderate cases. But you look at the NIH guidelines, they are talking about monoclonal antibodies, and they have given 3 antibodies, and they're talking about the last one, which is the GSK, so sotrovimab, which is effective even against the Omicron. However, it has been anticipated that the other 2 antibodies, that the Casimd or Bameti, are not likely to be effective against the COVID-19. But the antibodies are not something which can be given to all the patients, because obviously these are the antibodies which are not only expensive, but not even available for all of them. And the panel has clearly recommended no role of dexamethasone or steroids in non-hospitalized patients with COVID-19 as of date today. What about talking about this monoclonal antibodies or remdesivir? So you can see that last updated on December 23, 2021, very quickly updating, NIH included the remdesivir 3-day treatment at home in non-hospitalized patients, as well as using the new antibodies and cautioning against Omicron not being able to, or rather being able to evade the other 2 antibodies, which is the AstraZeneca and the Casimd, which is available in India. We have only one. So we have Casimd antibody, which is available, and they have given that it may not be effective. Now, another important aspect of this COVID-19 new wave, which has primarily come from what we say is South Africa, our Swaminathan, the WHO consultant, all we know her so well, has already said that this time the numbers are going to be huge. It is going to be fast and furious, but the entire burden is going to be of the non-hospitalized patients. So you need to be prepared to look after them in the OPDs. You need to be prepared to look at them at the telehealth services. So we need to have an early intervention for COVID-19 for particularly those patients who have got a high risk of progression. And to cut down that, you need to identify them in the first 5 days, because that's the time when there is a viral replication phase. And you need to act at that point, because this new Omicron has high infectivity and transmissibility, because if we act a little later, it has already spread in the community to so many people. And we know that almost 50 to 60% of community at the moment is having Omicron. We need to have a more genomic analysis, which is not available. Picking up on RT-PCRs again is a question. And then we have to remember that we have a comorbid and elderly population where we need to look into it. So can we look at it as monoclonal antibodies with the antivirals? And obviously we are majorly responsible to look at it that a viral disease is caused by a virus and needs to be dealt with an antiviral, because you need to quickly decrease the load of the virus, which is primarily the stimulator for the inflammation, which ultimately causes all damage in the COVID-19. So a clear unmet need is that we need an antiviral therapy, which should have a couple of characteristics. We need to tick mark all of these. It should be rapidly able to convert RT-PCR negative, so that the patient is not able to spread it across to the other members, like with Omicron. Decrease the risk of progression to severe disease, hospitalizations, death, and complications. And of course, it should be easy to administer, safe to use, and should have a minimal or no drug-to-drug interactions where a large comorbid population can use it. Presently, we have been using in the last wave is the favipiravir, and we know that there were lots of issues with that. I will not go into it. But yes, we need to improve the outcomes by having a better antiviral therapies. Whether we have arrived at that point or we are still trying to reach there is what is Dr. Kumar going to tell you. But I will bring to your notice this NIH updated guidelines of December 30, 2021. And the recommendation is that either use the new one, which is the Pfizer one, Paxlovid, which is a nirmatrelvir plus ritonavir twice daily for 5 days. Sotorvimab, which is 500 milligrams IV infusion, remdesivir 3 days course, or molnupiravir 800 milligrams twice a day for 5 days. So we do not know that whether it is going to be effective, but there is some data to suggest that the nirmatrelvir as well as sotorvimab and remdesivir are effective, and maybe molnupiravir, we do not know. I think that I'll leave to Kumar to tell us how effective it is. So I will hear from experts, and believe me, all friends, I'm on your side today, and I'm going to ask the panel all the questions which you want to ask them, and better equip yourself with treating this COVID-19 new wave which has arrived. Thank you, everyone, and over to Kumar.
Yeah, I think we would take the questions if they are coming in thick and fast. We would probably take them subsequently, and I would now probably invite Dr. Kumar Doshi for his deliberation on the session. Yeah.
Yeah, so I was just telling, thank you, Deepak, and I'm aware that I don't think there would be any doctor in the country who would not be scared of the volume of questions coming from Dr. Talwar. It can cut you across. So COVID, 2 years have gone by, almost going by, and we still don't know what to do. But there are few things which we know when to do. As Dr. Talwar rightly pointed out, we were not allowed to give remdesivir unless the disease was moderate, which by definition was after a while when the virus load is huge. And logically, as the Gilead trial proved later on, it started working when it was given in the early phase. So you want to use an antiviral or you want to use a monoclonal antibody, which is again going to work against the virus, it has to be in the viral phase. So we know that we have to give these drugs early, and that's why preferably in the first 5 days. Second, what not to give is steroids in the early phase of the disease. It's only in the later phase of the disease when it was found to be useful and reduce mortality. In fact, it was found that if you're going to use early, you're going to increase the mortality. So these things I think are very clear. At least we know what to do, when to do, what would be the choice is our only concern. As Dr. Talwar rightly pointed out, the choice at this point of time is that we don't have favipiravir as an option at all. We've all burnt our fingers, we've all prescribed, and we all realized that it just didn't work. It really gave rise to more GI toxicity than anything else, and all we were doing was selling hope. I'm not too sure whether we will not be doing the same thing again by selling hope, but there is at least some strong data, because the trials are going to come. When Dr. Talwar says we have reached there yet, certainly not. Our car has just started, but probably towards the right direction. So my presentation is going to be all about molnupiravir, and we'll just discuss how this drug came into being. I'll just skip the unnecessary slides. Yes. So this has been the roadmap of the drugs which came into picture. Vaccines, of course, you give very early on, and it's only in the very mild cases that Bameti and Casimd were to be given as monoclonal antibodies. Mild to moderate, again, Bameti and Casimd, we are still giving in critically ill patients double the dose of Casimd, and we are seeing response. And sotrovimab came into picture, specifically more active against Omicron. And the other three drugs, Molnu, Nirma, and are already there, which can work against the COVID variants of concern. A word of caution, 24th November was when the first Omicron got identified in South Africa, and we are just about 5 weeks from there. So there are no drugs which have, or no trials which have been specifically held against Omicron variant. It was only time is going to say whether all these drugs are going to prove useful, but let's see, I'll just describe as time goes by. And we have immunomodulators to be given to severe critical cases like Barci, Dexa, Tocilizumab, and Remdesivir as well. So molnupiravir, to begin with, it's an oral prodrug ribonucleoside analog of N-histocitidines, and the mechanism of action is by having a viral error catastrophe in recognizing. Can I just, if I could. Yep, here it is. So it is basically the viral error catastrophe. And it's this NHC was potent against SARS-CoV, against even remdesivir resistant variant. Now, this is quite interesting.
The slides are not on.
Sorry?
The slides are not on?
No, they're on from my side.
No, we are not on
If you
project.
can unshare and share once again.
I thought, Kumar, you are taking an extempore talk on this, so I never interfered.
No, I'm not doing any such thing.
I've only seen you actually.
Is it?
Yeah.
And I've been figuring around, wait, what's going wrong? I'll do again, slide share, and can you see it now?
Yes, now I think it is coming. Yeah, it has come now. Yeah.
Hang on. Okay, so the mechanism of action was that it is by a viral error catastrophe. Again, I have to put on my pen. Yes. Works by viral error catastrophe, and the NHC potent is even against SARS-CoV-2, active against remdesivir resistant variants. That was quite interesting. Now, if you were to see on this side, it showed inhibition of all the variants. It showed inhibition in alpha, beta, gamma, delta. What is missing is Omicron because it wasn't tested in the laboratory. So the mechanism of action is a bit different than favipiravir because it's a pyrimidine nucleoside analog, and favipiravir is a purine nucleoside analog, which requires an additional step for activation, that is by the HGPRT enzyme, and that requires a long onset of action, and thereby you have an extended therapeutic course, whereas molnupiravir acts quickly, and thereby you can have a shorter course. Plus, favipiravir has only one mechanism of action by the RDRP inhibition, whereas molnupiravir has an antiviral activity through the viral DA-RNA mutagenesis, and it escapes the RDRP action by proofreading and the chain elongation with delayed termination leading to self-viral apoptosis. So this is how we really expect molnupiravir to be of an antiviral effect. Now, even when they were compared head-on-head, these are all in vitro studies, even when they compared head-on-head with remdesivir and favipiravir, the antiviral activity was much better than both these molecules. Again, I would keep on giving you this caveat that it was tried only against the alpha, beta, gamma, delta, and not against OMI, as we all know, which came on 24th of November 2021. So it has got the approvals of US FDA, UK, Japan, Philippines, DGCA. Now we have to understand getting approval from these places doesn't mean it's a panacea. And you have to also understand these are all emergency use authorizations. And when you have EUAs, you have to bypass several steps. And we give it because there is nothing else better in the pipeline, and we expect it to act because there is an in vitro effect. There is one study which has come out with 1,400 patients, which I'll be describing, but I have to keep on giving you the caveat that it does not include Omicron. It is selective and effective oral antiviral drug suitable for outpatient clinical setting, short duration of action, 5 days. Early treatment molnupiravir provides effective clearance of virus, and the efficacy of molnu was unaffected by SARS-2 variant. Okay, whether it was gamma or mu with an underlying risk factor. So it basically ticks off all the boxes with Dr. Talwar was talking about what should be an ideal antiviral. So the clinical perspective, they started with a 2A study. They called it as a move out, which was a short study of 204 patients, which they only wanted to prove the efficacy and the tolerability of the drug. The primary outcome was time to viral RNA clearance, time to virus elimination, and the primary safety and tolerability objectives, which were also assessed. And they found that the proportion of participants who achieved SARS-CoV-2 viral negativity at the end of the study was greater for those administered molnupiravir 800 milligrams vis-a-vis placebo. So at the end of 5 days, even the placebo achieved 80% clearance. It's just that molnupiravir achieved 92% clearance. But this was again in that small 200 patient study, which was a phase 2A study, just was only for assessing the tolerability and proof of concept of it being an antiviral drug. I will quickly go on to the next part of the study, that was a move out phase 3 study. This was far more comprehensive and far more digestible. You have to see that it checked all the boxes of it being an ideal study. It was a phase 3 double-blind randomized, 1433 having mild or moderate COVID-19, having at least one characteristic or underlying medical condition associated with increased risk of severe illness. Please understand, the trial was also done for patients who had at least one characteristic medical condition associated with increased risk of severe illness. If you don't have any such characteristic, your patient actually doesn't qualify for this trial. If we are all going to sit down tomorrow in your cabins and start writing molnupiravir, it's going to be out of the market in probably next 7 days. That many patients you are going to have by the end of January. The numbers may be 25,000. To me, it's actually 50,000. There are huge number of self-help kits which are available, which patients are doing, reporting to me. I'm treating them, but from all I realize, they have not reported up to the authorities. So they're not even in the calculation as yet. The primary outcome is the percentage of patients who got hospitalized, percentage of the patient who had adverse events in the time frame of up to 7 months, and percentage of patients who discontinued the study intervention due to adverse events in a time frame up to 6 days. So interesting. Usually this part of the study is always very boring, but I found it very interesting. You have to see what was the demographics. 2/3 of the patients were less than 50. Only 1/3 of the patients were more than 50. So the younger group of patients. But 99%, it was a trial condition, all of them had at least one risk factor, where obesity was also considered to be a risk factor for the progression of severe disease. We always discount that, but it was one of the risk factors. So 2/3 were patients who were young patients, or I would say younger patients, and each one of them had at least one risk factor. The obesity definition, we all know we have to go by BMI, very well put up everywhere. We don't need to get into that. So at the end of the study, this was the best part. They found 30% reduction in hospitalization and death with hospitalization in molnupiravir, and 89% reduction in mortality when compared with the standard of care, when compared to standard of care and molnupiravir. In fact, even if you look symptom-wise, like all the patients who were mild and having variety of symptoms like vomiting or anosmia or diarrhea or cough or pulmonary or extrapulmonary symptoms, each one of those patient category having a specific type of symptom, the prevention to the severity was equally beneficial. So it's not that only a subgroup of patients in the upper respiratory tract benefited more, only the subgroup of patients who had loose motions benefited more. No, everyone, each subgroup of patients with a variety of symptoms benefited. So this was a study which is a mandate by Indian companies before rolling out the drug into the market. So again, this was an Indian study of 741 mild COVID-19 patients, and the comparison was standard of care versus standard of care plus molnupiravir, and the standard of care was given as per the ICMR guidelines and not like, in my opinion, type of prescriptions which we routinely see everywhere. According to the ICMR guidelines, standard of care plus molnupiravir vis-a-vis only standard of care, and that also they found the improvement, the clinical improvement, which was defined as a 2-point improvement in the WHO clinical progression scale at the end of day 5, day 10, day 14, consistently better with molnupiravir. In fact, they found that 63% of patients at the end of day 5 had that clinical improvement, and more than 80% of patients at the end of day 10 had clinical improvement, vis-a-vis about 50% of them had receiving only standard of care alone. SARS-CoV-2 RT-PCR negativity, to me, this has never been the most important part of any trial. Why should RT-PCR negativity be a part of it? Viral clearance doesn't mean that the virus disappears out of the body, but yet even molnupiravir, that also was great at the day 5. More than 75 or 77% of patients became RT-PCR negative. So median time to clinical improvement as early as 8 days in molnupiravir compared to 12 days in standard of care alone. So again, I would come back with folded hands and humbly state that this is not a panacea. This is not going to do any magic. Yes, there's going to be faster recovery. Yes, there is going to be faster getting better. Yes, the chances of mortality and the chances of progression to severe disease or hospitalizations are going to be lesser. But we have all this data with every other variant except the current variant, that is the Omicron. As far as safety was concerned, there was no mortality in either groups. Most common adverse events reported were nausea, diarrhea, headache, which were resolved completely. So, few caveats: molnupiravir is not authorized for patient less than 18, simply because it has not been tested as yet. Initiation of treatment in patients requiring immediate hospitalization due to COVID-19 at that stage. However, if it was initiated before the hospitalization to the because of COVID-19, it may be continued. Again, hospitalization as defined by criteria of hospitalization and not because of which patients get admitted today, whether we like it or not. I have patients admitted because they are panicked, because they feel that they'll be safer in the hospital. That does not take away the indication of they deserving molnupiravir. It should be used only for 5 days. It is not authorized for any extra extension in therapy. For pre-exposure or post-exposure prophylaxis, also it's not indicated. We have post-exposure prophylaxis indication for the Casimd, but not for molnupiravir, and it's not indicated in pregnant women as well. So non-hospitalized, I think Dr. Deepak has already gone through this, so I will not be going through this. But finally, same slide that the NIH on December 23rd came out that the Omicron variant includes numerous mutations in the spike protein, and thereby the monoclonal antibiotics of Bemeti and Casimd may not be very effective. And so that is how it stands today. But there are certain things how NIH comes out with the guidelines. It comes out with guidelines because when they say that more than 80% of your population is documented Omicron, that is the time it means that your standard line of therapy with Casimd may not be effective and go for Sotrovimab. At this point in time, as our figures stand, Delhi says that 50% of the strains are Omicron, and Mumbai says about 45% of the strains are Omicron. To me, it beats logic because I feel all of them are Omicron. Omicron is known to double in 2.5 days. And if we were to simply plot a graph of past 10 days, it's been doubling exactly by these numbers. It's exactly Omicron. So they're saying 40 or 50%, we will have to take it with a pinch of salt. With all due respects, they don't have that much capacity to do sequencing of thousands of patients in such a short duration of time. But we as clinicians will have to use our judgment that if this patient is probably Omicron and not Delta, he may not necessarily benefit with the antibody cocktail. Though I must humbly state that I myself have been giving cocktails to many patients which are having comorbid diseases, who are 60 plus with hypertension and diabetes, and with the numbers which are given to me officially that they are 35 to 40% prevalence, I have no heart to take away the benefit of cocktail, any possible benefit of cocktail from them, as long as they are willing to purchase the drug. So in summary, 80% of patients have early COVID, which needs an effective treatment. And now in some time, we are going to have 95% of patients who are going to have only early and mild COVID. Molnu is a broad spectrum oral antiviral drug. When we say broad spectrum, it has been tested only against alpha, beta, gamma, and delta. Unique mechanism of action, great for it. I hope it helps all the viruses. Mechanism of Molnu is independent of mutations in the spike protein. Clinical proven to be faster clearance of virus, reduction in hospitalizations, death, and faster resolution of symptoms. Shorter duration of treatment. That's what's most sexiest part of it. Most attractive. Short, 5 days, and stop it. No drug-to-drug interaction and acceptable safety profile, and it can be taken irrespective of food intake. With that, I wind up my talk and I open this for discussions. Dr. Talwar, please don't ask bleeding questions. You're mute. You're mute. Deepak, you're mute.
Kumar, I can't let you go away without answering the questions, because people are going to ask these questions, and if I don't do the justice, I will be doing wrong. Because now you have already said that, you know, we are very shortly going to hit those numbers, and obviously there is a lot of panic. There is a lot of panic in the patients, and they want to get admitted. Even if they have mild symptoms, they want to get admitted. So I do agree with you perfectly that we are seeing seemingly, you know, can you stop sharing the screen? Kumar,
stop. Yeah,
okay.
done.
Got a lot of questions here, and obviously some of the questions you have tried to answer, some of the questions, you know, we have no answer. And of course, I'll start with my panelist first, that and then come to you, as you have reviewed the data of Molnu Piravir. So I think the first question which would come, and I think Jay, I will come to you, Jay Chandra, that when would you initiate oral antivirals among patients with mild to moderate COVID-19? Now, you know, we have all discussed this. So like how are you going to initiate it?
See, we have just started seeing this Omicron. And even with Delta and other things, we found that nearly 80% of the patients really don't require anything more than a paracetamol or something else, if you are able to convince them, that is. This is not going to be any different. But the only thing is the sheer numbers are going to get us into a panic mode, wherein probably the patient is going to decide that I'm going to take Molnu. Okay. See, this is going to be a problem because it's going to be available and it is not so expensive. So people would say, why do I want to take a chance? I want to take it. Whether I'm younger, older, with morbid or comorbid conditions or not. But if you go scientifically, probably we will all look for those people with little bit of risk factors, whether it is obesity, whether it is diabetes or something else, but still having a mild disease, who's got a probable, you know, our own prediction that he may deteriorate faster, we would like to initiate him in that. And then again, as you have already mentioned about the recent, are we going to use this as a first line of defense? Probably it comes fourth in the list if you have all the things. But again, depending on the availability of the rest of the three drugs. Remdesivir could be a cheaper alternative, or probably more efficacious drug right now. Molnu, yes, it's available, freely available. Now the market is flooded with this particular drug. You don't know whether you really would have a choice to prescribe it or not. That is going to be the question.
I think, Jay, what you are trying to hint at is that if the 14 companies are going to bring the molecule, then there shouldn't be a shortage of the molecule. I think that's what you are trying to hint. And you are also bringing in deja vu of favipiravir, where, you know, patients themselves decided to take favipiravir without asking anybody.
Exactly. That's what I'm trying to tell you. Whether you'll be given the option of prescribing it or not, or whether you'll be forced to prescribe it.
Okay, so I think Kumar has given a very good, description that this has been used when the patient has at least one risk factor for progression of the disease. Every Tom, Dick and Harry who has a positive report does not meet. I'm seeing a question here which says, even if the patient is asymptomatic and RT-PCR positive, why not to use molnupiravir? So, Kumar, what is your answer to that? Jay says no.
Absolutely. That's what I'm trying to tell you. like I put my cards on table, Deepak. I have not given more than 20 favipiravir ever since it came, uh, which is directly proportional to the very few number of patients which come to me. So I have a very poor practice. So I have given only 20 number of favipiravir. So it's up to you. You put your foot down. No, sir, you don't need it. First, he will go and ask somewhere else and take it. So be it. So be it. But if you are just an incidental RT-PCR positive, I just tell my patients, yes, you can take molnupiravir. You were not symptomatic earlier. You will definitely become symptomatic after molnupiravir.
So, Dr. Pradyuman, what will be your take when the patient tells you that I have RT-PCR positive and I have mild symptoms and I have heard that this drug has come? Can I use that?
So, rather, one should never be scared of his practice. One should not fear because the patient may go away. Most of the physicians, they have a phenomena that patient may go away. Because the patient, if you don't write a favipiravir, they take it that you are not a doctor. We know better than you. So that's a very difficult question. So the counsel is very important. You have to make them understand because once a patient comes to you, he has taken a Google Baba or he has taken many other local Googles also. And they all tell you, oh, why not to take this? Tum le lo. Kya dikkat hai tumhe lene mein? So the point is you have to be very confident about yourself. Do not be taken away by the idea of the patient. Don't try to sweep away. You have to identify a patient because many times the drug may not do good, but may do something indirectly, may affect your health also. And number two, now it carries a wrong message in the family because the way Omicron is spreading up, you don't find a one in a family. You find most of the people in family that are positive. So the point is, the message should not be taken away that anyone can take it. A child of 20 years can take it. Why should we take it? So you have to be very definite your guidelines. You have to be very definite your academic criteria that it has to be classified according to the guidelines laid down to you, according to the medical ethics. So don't try to do out the practice. Don't see the scenario that way. Very confident. See the parameters. See the age of the patient. See the BMI of the patient, obesity of the patient, see his sugar levels, whether he's a type 1 diabetic or whether he is an uncontrolled beta diabetic, see his pregnancy status, he's a because at that age is not different. So there are many patients, any evidence of the heart ailment, associated hypertension, renal failure. So comorbidity has to be there to prescribe a drug. Only then you will get advantage as a non-hospitalized patient. Number one. Number two, you have to be proactive also. Because out of the 100, only 1 or 2 patients may need it. So very true enough, you have to see the patients. And like the other drug, Paxlovid, has a lot of drug incompatibility. But molnupiravir is a very safe. If you try to see these two molecules, is a very safe molecule, very safe clinical profile, very less side effects, and very good clinical efficacy. But still, do not try to overprescribe it. To be confident, and you should adhere to the guidelines that though it is a better drug than because past drugs, antivirals, but inhibitors is an analog. It just inhibits by competition, by making a mutagenesis. So the molecule is good, but could it not be another antiviral? We all started with the ritonavir, then we came down to HCQ, zinc, vitamin C. So then don't try to make it that way because a message carrier on will be maybe wrong. Try to justify with the molecule, try to justify your practice, try to justify with the patient and see who needs it. Prioritizing the practice is not important. Prioritizing patient is more important. That's my message.
I think your message is very crystal clear, Dr. Pradyuman. But I am an innocent patient sitting on the other side and asking you, what is the harm, doctor, in my taking the medicine?
So very true. Very true. That's where the counseling comes. So what is the point? Why do you want to take it? The logic is don't answer his text.
It's a drug which has been shown to be effective and everybody is talking about. And last 1 year, we have been hearing about it in the news. Merck has been making very, very nice statements all throughout, pushed it. And this is one disease where every patient is very well known about what is going on. My group of patients who come to me or like me will say that, okay, I think Kumar very nicely said only 20 patients of favipiravir. 20 patients is in one family itself actually which took favipiravir. I won't say that. And that is because, and they don't ask anybody. They don't ask anybody because they know that this is the treatment which is going on. So I think that message of two things which I feel are very important. You correct me right, all three of my panelists, that one, we know that this drug is, as far as we know, it is safe. But then safety is not an absolute terms always. So we do not know. When you use, you know it, your body may not actually accept it. Two, we do not know whether it is even effective in Omicron or not. Three, that it is effective when it is already showing the effects in those people who have that high risk factors actually. So I think all these points need to be discussed, and this time it will not be a cut, copy, paste prescriptions which have happened in Delta wave. I think you really need to look closely into the patients and then take a call. I think that's the very clear message from the panelists, that no doubt it is an antiviral drug. It is an oral pill. It has been shown to be effective to the tune of 30% decrease in hospitalizations, which according to me is not a huge number, but 80% or 83% reduction in death, which is an important number. But I remember that even Merck changed it for US FDA last minute. From this figure of what is called as 83, it was brought to 70%, because some of the centers which had not reported accurately, they were finally included into the data analysis, and the analysis outcome changed. So it was brought still to 70%, but still 70% is a good number. So if you are at high risk for death, then definitely it makes a point. It definitely makes a point. But then I will turn the table now to my panelists again. Now we are going to see a lot of telehealth services. Patients won't be walking to the clinics. They will be calling us as they used to call with a Delta wave. How can you assure the comorbidities and the other risk factor screening while seeing that whether the patient is a candidate for a molnupiravir or not? So Dr. Jaya, how will you take that? Because tele will be very commonly used now.
Yeah, tele is going to be used. That's only going to be good for giving general advice. But giving a prescription on the telephone without examining or without knowing anything about the patient, that's going to be a little dicey. I would rather avoid doing that. Yeah, but this is going to be inevitable. The sheer numbers are going to overwhelm you. That's going to be the issue now. You can't be sitting in the outpatient looking at a physical crowd of about 50, 60, 70 people there and doing telecalls. You're going to be busy 24/7. And I don't think that's the right way to go about it. I think, yes, telemedicine is good for follow-ups. But as a primary point of contact for giving a prescription, you need to see the patient physically.
Right. Doshi, how are you going to manage the telemedicine services advice, which you are already doing it actually? You said that your patients are already telling you that they are positive. What to do? You please unmute yourself.
It's a catch-22. Somebody calling me and saying I'm positive, and you take a history, say I'm hypertensive. And then I ask, his age is 45 years of age and is taking 2.5 milligrams amlodipine a day. So you wonder whether that is an enough comorbidity. Should I consider it as a part of generalized arteriosclerosis, thickened arteries? Is this going to be really having any significance? I have never seen this patient earlier. Vis-a-vis his own family practitioner, who might have seen him 100 times in the past and even had the pressures monitored, and sometimes he's seen spikes, and he says, yes, this is a significant morbidity, because earlier you have larger medicines than the smaller medicines. The point I'm trying to cut across is this drug is not going to be prescribed by you and me to the masses. We are going to treat probably even 5% of the actual COVID cases in the community. 95% of the patients are going to be treated by the primary care people who know their patients well. And the message from all of us to all the primary care who are listening to us is, please do not give your patient unless he has at least one comorbidity. As Dr. Deepak's question to me, if he's going to call me and I'm not convinced, is 45, just mild hypertensive, I would say, wait for a day. Let's see how the disease progresses. Get your markers done. If your markers are also normal, all of you must have seen, and that's what I have been seeing since past 10, 15 days with this Omicron coming up. Most of the patients' markers are near normal. CRP is modestly elevated by a factor of 2. D-dimers are normal for practically everyone. Lymphocytes are more than 1,000 for every single patient. So this disease probably is behaving in a much milder way, though might have severe symptoms of headache and fever and everything else, but otherwise they are normal. So we need to be very clear as to the absence of comorbidities or risk factors, no molnupiravir, and the same message going to the primary care who can do the same to their patients. Larger percentage of population would be served with more rational prescriptions of molnupiravir.
So Dr. Pradyuman, what is your take on this, that if the patient has more severe symptoms, like fever is high grade, patient has got severe sore throat, running nose, and body pains, will that or a markers, as I think Doshi said, so I am of the opinion no markers to be done. But then obviously patients have memories. They have very short memories of Delta. They will bring their own reports. And I am sure that also stupid markers of no value will be done n number of times, giving money only to this laboratories which are churning the reports. And at least lots of them are actually wrong even. And they will be just churning the reports left, right, and center. How will you rate these two situations when the symptoms are more severe or markers? Patient comes with, says, my markers are already elevated. See the CRP, already it has reached 20.
The point is this: we have to trust the patient, number one. Number two, we have to take the message whether it is only Omicron, because in a pandemic, everyone may not be an Omicron. There could be associated some other factors. There could be some associated bacterial infection, or could be a Delta, because there has been Delmicron also. He can have a Delta with Omicron, and there will be person reported with Alpha presence and Beta presence and Delta also. So there can be many pictures also. And now there have been some of the complications has come up. There has been influenza with Omicron. Recently, there was today, there was at 2 o'clock, there was a guidelines, there have been information in Indian Express that a patient who is suffering from influenza itself, so he may be asymptomatic primarily because of influenza also. So he may have a high fever, upper respiratory infection, rhinorrhea, sneezing, cough, itchy throat, and maybe having a 100 fever, 100.5 fever. But we have to again rationalize. Identify the disease. RT-PCR positive only does not mean that you Omicron, because and everyone cannot go for a genome sequencing also, because that tells you in a 4 days story also. And suppose it's going to be bad disease, you are out of the reach. And that's again no point right now to start with molnupiravir. So rationalizing the patient, do not think in one guideline. You have to have a broad spectrum. You don't have to be like a horse in a tonga. Because of all the carriers that he is tubular vision. Don't try to be tubular vision. Always keep a wide vision and assess the patient. See many times what happens. मेरे को बहुत fever हो गया. अरे भाई कितना डिग्री? सर बहुत fever है. अरे भाई डिग्री के नापा नहीं. अरे बहुत तेज blood pressure है. बहुत high blood pressure हो गया नापा नहीं. So the point is always assess what the patient is saying. Number one. Number two, the past history is very significant. And the comorbid, because once even in telehealth, I do believe in telehealth, but with certain riders, not the first consultation, but follow-up consultations are very informative, very important, cutting down the patient's time, traveling time, and exposure to the other patients also, to the family also. Because of one family carries down a patient to the hospital, and rest of the family do suffer again from the same disease, right? Because it is a very high R value, the way things are going bad. Assessing a patient, do not believe what he says, but assess a patient and see any other comorbidity, any other infection may not exist. And you find something does not, it is not Omicron, because Omicron, they are not clinically that significant. Number one, Omicron does never come with your cough. It spares your lungs. You can have severe lethargy, weakness, body ache, GI disturbance, but at least it spares your lungs, it spares your upper respiratory system. Looking for second disease is always a better answer. Always be inquisitive, see the patient, believe your clinical sense, and some of the basic parameters, don't try to overdo the things. Don't try to trust your laboratory. See the clinical evidence and then handle the patient. That's my message. But I believe in telehealth, but not as a first consultation, but follow-up consultation.
Jay, you want to make any comment here on this particular aspect? Or you ditto?
Yeah, see, basically, I'll tell you what. I started my statement saying that 80% of the people don't require anything. Now, the problem is, how do you categorize this 20% of the people who really qualify to get an antiviral drug? Yeah, you say that, yes, we have had people with comorbid conditions, you would want to give it to them, reserve it for those people. Fine. I mean, these are all the guidelines. I mean, we have no dispute about that. The problem comes in is when a young fellow starts to deteriorate and you had not made a choice of giving him a drug. Because even with the earlier variant, with Delta, we have had a lot of younger people who really had no comorbid conditions suddenly go down the chute. So is our assessment of the patients who come to us so strong that we are able to predict 100% who is going to deteriorate and who is not going to deteriorate? See, with Delta, we had seen people coming in with 80 years of age, coming in and walking out of the hospital with no issues at all. But we have had 25, 30-year-old guys coming.
So what do you suggest? What do you suggest? You have contradicted yourself actually now. No. You said that we are not able to identify. If we are not able to identify, then what?
That's precisely the point I'm trying to make. We are going to miss some people who do not qualify for an oral antiviral drug because some of them are sure to go down the chute, even if they're younger without any comorbid conditions. Because recently,
I think what you're coming to is that there are going to be fence sitters, like Kumar had brought a beautiful question that amlodipine 2.5 milligram. So as per, if you look at it, it is a hypertension. Hypertension is an hypertension. Yes. Similarly, if somebody is 59 years and you need to be 60 to get the drug, that doesn't make a sense actually. That obviously will be fence sitters, which will require a decision to be taken by the physician. Actually, that's a physician's call. He has to decide.
The point I'm trying to make, guidelines are fine. Use them as guidelines. Use your judgment in every case.
Right now, we don't have Indian guidelines at the moment, which are telling us to use it even.
No, yes, but I think Dr. Sharma made a very good point that, clinical assessment, again, forms the basis. Guidelines are there to give you broad guidelines. Don't go with absolutely like a rigid system. Use the guidelines, use your clinical judgment, and then go ahead.
Yes, Kumar, you wanted to say something?
Yeah, as Dr. Jayachandra was talking about young fellows going down the chute very rapidly, and we saw all that during Delta, practically once in a day it used to happen. Now, we need to, that's why I started that the NIH comes out with guidelines depending on what is a prevalent strain, because they are doing huge number of sequencing. And they have the HGTF kits, which tells them whether it is a Omicron or whether it is a Delta. Unfortunately, we are still not using the SGTF kits, which are, to my knowledge, already there with the government, but they're not using it for everyone's use. Forget about whatever they're using or not using. Once we know that the prevalent strain is Delta, like we all know the most common cause of fever of unknown origin in India is tuberculosis. And if you can't find any reason, we do give them a trial of anti-TB drugs. Similarly, once we know that the most prevalent strain is Omicron, it also tells me that the likelihood of this gentleman having a sudden deterioration is far lesser than what happened earlier. And thereby having a knee-jerk reaction or a decision made out of panic because of the relatives wanting to start, we can be much more confident in saying that no, he doesn't need no comorbidities, no drugs. So we are unlikely to miss any patients who may probably go down the chute rapidly and in the hindsight kind of repent that I should have treated him, but I missed the opportunity and he went down. This is unlikely to happen this time around. That's my gut feeling. I want everyone else input in this.
No, we all agree with you on this. There's no doubt about that. What I'm saying is our experience with Omicron is rather sketchy. It's just coming and it is coming as a deluge. So we need to put our best foot forward. And, experience tells us that, yeah, you don't have to be really so serious about this problem, you can watch these guys much better. But the only problem is you have only a 5-day window period when we're going to start all these things. In that 5 days, you need to decide everything. And that's the issue.
In fact, it's an antiviral. Why we should wait even 5 days? Why not on the day itself, actually? If your call is to take and start an antiviral, it should be started on the day the patient reports.
But he presents to you on the second or the third day.
He might even
What he means is the day of presentation.
He might even present later on. There is already a question coming on the chat box that whether you should start it at day 4 or day 5 and waiting and then starting it. So I think that the answer to that would be, Kumar, what is the answer is to this? You should give it, if you have taken a call to give it as soon as possible.
As early as possible, because let's go back to the monoclonals. Casimd, they said give it in the first 5 days, then said it can be given not later than 7 days. And now we are giving it to even moderate and severe cases. So we know that the viremic phase is in the first 7 days. So it's very likely that the patient is going to present to you in the first 7 days. So give it at presentation if everything is in the line. And what do you have to check? A COVID positive report and a presence of one comorbidity. Yes, no problem.
So I think that sums very well, that COVID positive and a one comorbidity. On the other hand, we are getting questions here that can you give it without your antigen, without the test positivity, because it is considered positive, like it has happened with Delta, reminding me of the Delta things. Well, I also asked the question that can you use only a rapid antigen test positive to be considered as giving the drug?
No,
rapid antigen is not a problem, but as far as the other thing is concerned, if you don't have it, why should you take it? Actually, if the test has not been done, that's not an indication to use it.
Absolutely not.
But there is another point there, I think, Kumar, that is if somebody in the family has got already a COVID positive and there are other people who are running symptoms and they are in the high risk group, what to do for them?
So this is exactly why I come back to my Omicron hypothesis. It's time that India declares, and I'm willing to be on record over this. It's time that we all declare that Omicron is the dominant strain at this point in time. Once we all accept this, and you have a case in the family, and if somebody else has the similar symptom, he should be deemed positive.
And especially if that is the high risk group. If he's in the high risk group.
The high risk group, we are going to do only for making a therapeutic decision of molnupiravir or any other drug. Because unfortunately, sotrovimab is not available. Only Casimd available. Otherwise, Casimd was even a license for giving post-exposure prophylaxis.
Okay, so Dr. Pradyuman, in case you have to see this patient, like you are seeing day 4, day 5, will you, and the patient fits in the bill for using a drug, would you use Casimd or will you use molnupiravir? Considering that 5 days of molnupiravir is required and 1 day of giving Casimd.
So the point is this, Cassie, number one, you have to be a skilled person. The patient has to be given by a skilled person the injection shot, maybe at home, but has to be with a skilled person, number one. Number two, the price is a factor. So the point is this, in today's time, this is set out to the best molecule because the mutation has taken place as RBD. There have been 32 mutations, 50 mutations spike protein. And that's absolutely to a spike. While it is a viral, it causes a mutagenesis. It just behaves like an analog. I believe this is a better molecule than monoclonal antibody, number one. Number two, looking at the price, looking at the simplicity, we can comfortably give it. Number three, even in telehealth, if you find the patients are morbid, because if you see a scenario of diabetes, at the age of 20, every 11th person is a diabetic, but the age of 60, every 5th person is diabetic. Number C, obesity. At the age of 60, every 3rd person is obese. If you're taking all the parameters, COPD, this is the third killing disease all over the world. It's a neutrophilic asthmatic disease. So the point is at the age of 60, you're finding a person is hypertensive, had undergone probably some of the third person has taken an angioplasty or every third person is hypertensive, every fifth person is a COPD patient, and someone has a renal dysfunction also. Associated, some metabolic disorders are always associated. 1 or 10 out of may have some OSA associated obesity also. They are the persons to be prioritized, not to spare them off, but to give them the best oral antiviral drug which is available today in time. That's probably molnupiravir. I am a strong proactive to certain patients who have been following this guideline past the age of 60.
I think very
Probably you will
strong
find.
message from your side.
Yeah,
Very, very well
exactly.
taken. Very strong
Exactly.
message from your side. I
Take home
suppose.
message.
A
Yes.
very take-home big message. And so you have profiled your patients, 60 years above, with so many list of comorbidities. I think you have nicely profiled the patients who should get molnupiravir.
So I have one question from all of us to you. I'm sure it must be there in the chat box also. Can you give molnupiravir and the antibody cocktail to the same patient? Day one cocktail and follow it up with molnupiravir for the next 5 days. Best of both the worlds.
So Kumar, I think this question has come to me, has come to my mind. I have a very clear understanding that if I have a severely immunosuppressed patient, I would use both of them together. So that severe immunosuppressed are our lung transplant patients, bone marrow transplant patients, patients who are on heavy dosages, who have received recently rituximab and other injections, where I'm really worried about them. I would use them. This is my take only. I can't be quoted on to this because
No,
I do not know.
Again, you are profiling severe immunosuppression with specific conditions. It doesn't mean that somebody on 15-20 milligrams of steroids is severely immunosuppressed.
Absolutely. No.
It's very important.
So a very clear amount of immunosuppression is like something which you need to consider. And I would also humbly submit that, see, we are talking about Omicron experience of South Africa, of UK, of US. We are forgetting that, their seroconversions and immunizations and the vaccines have been different than what has been in India. India has to generate its own experience of when with people with Covishield and Covaxin get Omicron, what happens to them. So I think we have a total new area where we need to keep ourselves, I would say rather tune in for whatever is new coming in. So this is not the end of it. And I'm sure that there's a lot more to come. There was one question as how you fare favipiravir versus molnupiravir. I think I will take a prerogative here and I will say that no comparison at the moment. Please don't compare these two drugs at all. Everybody has the experience of that. This one, people are using it. The data, I think Kumar has very rightly said that data is definitely more convincing about the drug, which is molnupiravir, and no doubt the whole world is talking about it. So, but then the real the taste in the desert is when you use it. So when you get the experience of using it. So maybe that Torrent will organize one more webinar after 1 month of usage of molnupiravir and ask the consultants how they feel about it. What is the experience with the Omicron? And I'm sure, Kumar, what you said is that sooner or later it will be declared that we are Omicron all over. It will be sooner or later.
I will tell you the data. I serve a local municipal hospital, that is Rajawadi, a private place. In the private hospital, out of 80 beds, we have only 13 admissions, and of the 13 admissions, 7 were for antibody cocktails. That is today's story. And in the municipal corporation, the Rajawadi hospital, out of 50 allotted beds, we have only 4 admissions. And that is a time when we have today reported 6,500 cases in the city. So that speaks about the current deluge. Like, that's the data coming from the ground, that the deluge of patients is there. As you rightly said, most are going to be mild and the non-hospitalized. So the decisions of Molnu will always be given credence, but the severity does not seem to be there.
Yeah. The other thing is the prevalence of casirivimab for Omicron may not be very useful, really. Probably you'll have to hold on. And the only choice you're left with at this point of time is the oral antiviral drug that you're talking about.
Very true. I
Is the other one which is there.
Omicron story as well as the the monoclonal Casim is concerned is not very clear. But that is why I said that if the patient is heavily immunosuppressed, I'll use both of them. I will not leave the patient only on the fate of one particular thing to be looked after.
I think that's
any last message, Dr. Pradyuman, you want to give?
Yeah, the message is that still we have to identify a large number of people who are suffering from skin disease, rheumatoid arthritis. They're already on a high dose of steroids. Number one, there are high doses of methotrexate. So the classification comes out. A person who is taking 15 milligram methotrexate for a week, or azathioprine, or steroids 20 milligram a day, they are classified as an immunocompromised also. In such scenario, we have to prioritize the molecule. We have to rationalize the molecule. We have to be clinicians, not just putting a molecule over there. So always rationalizing molecule is very important, and it should be supported with all documentation. Though we understand the phase 3 guidelines, but 1,433 patients is a small number. But India could be another leading factor in the world to demonstrate, to see the large number of the patients. We have so much beautiful, lovely clinicians with us, and we can better rate ourselves. We can come out more better study in favor of molnupiravir. And I believe we may have to see a better tomorrow, because daily we are learning it is a super bug, or rather we as a hybrid bug, and what it can do, because today there have been cases of floronova. They are suffering from influenza and the same Delta also.
We didn't
But
see
there's
that.
another
report.
This is a common scenario which is going on. So, okay, dear
it's
friends,
a common scenario. That's what I told you, because you said patient having a
especially with the vaccine not covering the present influenza strain, which is another thing which has come up with the controversy. So, dear friends, you all have heard the experts. You have heard the experts talking about two things: monoclonal antibodies and a molnupiravir. Two things which you are armed with to treat your non-hospitalized patients. You need to prioritize your patient according to various factors which are going to account for whether the patient needs A, B, or nil. The A would be perhaps depending upon the amount of immunosuppression they have, the risk factors, the comorbidities, and of course, many other factors which are involved in it. Actually, if the patient had a very severe disease in the last one, that itself is an indicator that the patient may go bad in future also. So actually, this time, the job is going to be very seriously done by clinicians in choosing their patients as to give A, B, C, and I would say remdesivir is also coming up with a very good data. Actually, I would personally consider that if there is a real difficulty, I will say go ahead and take remdesivir 3 days. That's the drug which we have used extensively, and we know that it works at the right time only. The only problem is the wrong time of administration, which led to disasters with remdesivir. So I think we have these three options to deal with non-hospitalized patients. We should be able to do it better. And of course, as I brought in the telehealth services, I've already a question mark, because you do not know that patient at all. Actually, you have no idea what that patient has, and suddenly popped up with those kind of things. So I think if the number of patients are high, we are forced to do the teleservices. But these are the challenges which we will face and come with the answers in a couple of days from now onwards. So I think all of you tune in. Maybe in 2 to 3 weeks, you will get much more information on not only molnupiravir, but also on Omicron and its effect, what we are getting in India. With that, I would like to thank all the viewers and my panelists for with me, as well as speaker, Dr. Kumar, for excellently delivering the beautiful talk on molnupiravir. I give the proceedings back to Krishna, the organizers for the torrent, and thank you all.
Only one comment. When Dr. Jayachandra was saying what is left behind, so I was about to say that he's going to complete the sentence with what is left behind, sit back and enjoy a glass of wine. You're mute. You're mute.
Abhi picture baki hai. That's what I wanted to say.
I think that's truly said and well said. When we are looking at this current flux and challenges of an unseen enemy, probably coming out with unseen foes, notwithstanding the vaccination status, which is probably getting all the more scaled up, I think when do we have to suspect and probabilize test, and when do we test? I think that was also very well highlighted. When do we test? And when you're looking at a probable case, I think as an ideal oral antiviral, there are several characteristics of molnupiravir, which makes it an apt probability-wise choice. So with that, I would thank once again this distinguished panel for triggering the thoughts on this new challenges. And as I'm speaking, so there are new set of communication series which are hitting the media bites, and we all hope, as Dr. Talwar has already said, that after 2 weeks, maybe the picture would be a better reflection. And probably again going ahead, as highlighted by Dr. Pradyum, saying the fact that yes, probably we will have to probably look towards an real world assessment with a much more pragmatic study design. And all of these initiatives will be coming in very thick and fast coming from our soil. So thank you once again, also the delegates, for taking the time out, and rest assured it was a wonderful deliberation and sessions, and we would like to come back with some of the questions which are still coming in, but I am rest assured that yes, the panel would come back and respond to them subsequently. Thank you once again.
Thank you. Thank you. Good night.
Everyone. Thank you.